We've got a couple of people over on the Facebook live stream.
It's amazing. It would be so wonderful. I mean, I recognize so many faces and names, but can everybody introduce themselves in the chat? I think it would be wonderful to say where in the world you are and if you're affiliated with an ICI site or partner organization and anything that you'd like to say so we can bring our community all together.
I just wanted to share, oh, okay, from on Facebook, because we can't get the comments to go across, but we have Mary from Kumpio Midwife Clinic in the Philippines watching on Facebook, and we have Narissa Kumpio, who is the founder of the clinic in the Philippines, over on the Facebook live stream. So when we get to discussion, I will be going over to Facebook to grab people's comments and questions. We have a pretty full program, so I think we will get started. Um, unless there's any housekeeping issues. I think we are good. All right. Bear with me. This is our first time live streaming the Zoom, so please be patient as we see how this goes. And we have a lot of presenters, which is fantastic. But the goal for this is to do about half of this as presentation and then half as discussion. So we want to make sure, please go ahead and put your comments and your questions in the chat, and we will, Sarah Hinton, who is working with us, is with ICI, will be grabbing those comments and questions for when we get to that portion of the discussion. Okay, so welcome everyone. I'm really thrilled that so many of you could be here to join us. This webinar series is meant to really generate dialogue between many of the ICI facilities around the world. I can see we have many different countries online. And for anyone who is interested in joining in on these conversations. So I really appreciate all of you making the time today. If anyone's having difficulty with their Zoom connection, we are also streaming on Facebook if that is better for your bandwidth. The Facebook live stream is on the International Childbirth Initiative Partners Facebook group. It's not on the main, well, it's linked from the main ICI Facebook page, so you can find us there as well. This is the first of the 2024 webinar series. And we're going to be talking about Doulas and Labor Companions, a global discussion. My name is Michelle Scartharian. I'm sorry, I've been talking a lot without introducing myself. I'm the Executive Director of the International Childbirth Initiative. Also with us today is Deborah Pascal-Bonero. Deborah, do you want to say a quick hello?
Sure. Hello, everyone. I am the co-chair of the International Childbirth Initiative. And for everyone on live stream, we're so glad you're here. And everyone here that we can see in the comments in the chat, maybe Michelle, at the end, we can read where everybody's from because it just warms my heart. Welcome, everyone, to see everyone joining from around the world as we come together today and all the time for the International Childbirth Initiative. So welcome and thank you.
Thank you, Deborah. And I think almost everybody here is already familiar with ICI, but if we have any newcomers, welcome. ICI provides a framework for the implementation of safe and respectful maternity care, maternal and newborn care practices and policies through the 12 steps for safe and respectful mother, baby, family-centered maternity care. It's implemented through individual health facilities. Several of them are going to be presenting today through self-evaluation, reflection, goal setting, and community participation. We provide a global resource network striving to share our learning as we are coming together to do today. And ICI was created by FIGO, the International Federation of Gynecology and Obstetrics, along with the International Mother-Baby Childbirth Organization, for which Deborah is the chair, along with the International Confederation of Midwives, the International Pediatric Association, and the White Ribbon Alliance. And then we also have many other endorsing partners. I'd like to give special thanks to IMBCO. I'm not sure, is Ray here? I haven't seen Ray if you're here. Ray Davies and Mary Leslie, they have been helping us to rally the speakers for this webinar series. It's been a very long process. IMBCO is very active in supporting ICI, including managing our fundraising. If there's anyone who wants to support ICI, we do get donations through IMBCO. Those all go directly to ICI, which we're really grateful for their support in that. Oh, and we're also open to any facilities who are willing to commit to delivering safe and respectful care. So these are many of our partners. And then today's presentations are really going to be focused on step 4, which is to inform the mother of the benefits of continuous support during labor and birth, and affirming her right to receive such support from the companions of her choice. Those companions can be the father, partner, family member, a friend, a doula, or a labor companion, as well as a traditional birth attendant. And a lot of this presentation today will be focused on doulas and other labor companions. Continuous support during labor improves outcomes for women and newborns, including a positive birth experience, an increase in spontaneous vaginal birth, a shorter duration of labor, a decrease in the number of cesarean sections and instrumental vaginal births, less use of pain medication, and reduced frequency of low 5-minute APGAR scores. And this continuous support appears to be the most beneficial when it's given by a person who is present solely to support the woman and is not a member of the, I'm sorry, we had a pop-up there. Continuous support is most beneficial when it's given by someone who is present solely there to provide support. She is not a member of the woman's own network and is experienced in providing labor support with at least a modest amount of training, such as a doula. For those of you, I saw someone just requested to record. We are recording today, and it will be shared on the ICI YouTube page when we are finished. So we will send you a notification because you're registered for this. We will email you when that recording is available. So I am going to go ahead and pass this over to Ghana. Do you want to go ahead and share your screen and introduce yourself? Oh, I'm sorry. I wanted to also give you a quick overview. We are going to have presentations from the public and private hospital in Mongolia, as well as the university that provided their doula training. And then we are going to go on to a presentation from Lwala Community Alliance in Kenya, along with Esther Kimani. And then we are going to go on to Thamini Uhai in Tanzania. So Ghana, you can go ahead and take it away. We're going to try to keep it short, around 7 to 10 minutes per presentation. So we have a lot, even though we have a lot of presenters, we want to make sure we get through this quickly and have a lot of time for discussion.
Yeah, hello, everyone. So my name is Ganchimeg. I'm from Mongolia, but I'm working in Japan as assistant professor. And we, the Mongolian team, we have the public hospital, and another is a private hospital. And also we collaborating with the Mongolian Health Science University, which is providing for training for doula. And now I have a 3 presentation. The first one is the professor at the Mongolian Nursing School of Nursing, Mongolian Health Science University, and her name is Tsetsegmaa. So she's going to present about how the doula training going on in Mongolia. 说她越好. So Tsetsegmaa, I would like to present her. Oh, sorry. I need to check. Tsetsegmaa, do you have?
Okay.
Yeah.
Hello, everybody. I'm happy to present to you the work of my team. Today I want to introduce the history of the preparation of doulas in Mongolia. My name is Tsetsegmaa. I'm the head of Department Midwifery and Maternal Child Nursing, School of Nursing, Mongolian National University of Medical Sciences. There are barriers to providing one-to-one continuous support, labor and delivery in many countries, including Mongolia. Therefore, we implemented models to support a group of women with one health provider simultaneously in public maternity hospital. On the initiative of lecturers Ganchimeg and Rieko of the University of Tsukuba, Japan, a two-day meeting and seminar attended by doctors and midwives from Mongolian maternity hospitals was held, and as a result of listening to the opinions of the participants, they introduced both doulas in Mongolia considered possible. In 2018, a 10-day course was held from undergraduate midwifery students in the form of lectures, seminars, and internship in cooperation with the above lectures. In 2020, together with two teachers, I conducted a 3-day training for midwives and nurses in Ulaanbaatar maternity hospitals. Currently, with companionship training is being conducted in Ulaanbaatar city and Darkhanul, Orkhon and Bulgan province. Between 2020 and 2023, a total of 320 people participated in the World Companionship training course, which included hospital midwives, nurses, and assisted nurses. There are pictures of the training that took place at the hospitals. Okay. Okay. Between 2018 and 2024, a total of 350 midwifery students participated in the World Companionship training course. There are pictures of the training that took place at the School of Nursing. Okay. We prepared and used some items in our training. This is we work together to organization. The first of Department of Global Health Nursing, University of Tsukuba in Japan. Second is Doulas Association, Mongolia. Thank you. Thank you for paying attention.
Okay. Next, I would like to ask the Mongolian, the private hospital, the Gorungal. The presenter will be the Munguntsetseg pediatrician, neonatologist. Munguntsetseg, would you please? Can you share your slide?
Thank you so much. Okay. Can I share my slide from my computer?
If you can, okay,
You
yeah.
guys see my screen?
Yes. You
Okay,
make it
thank you. Okay, let me.
the full screen.
Okay. Thank you so much. Good morning and good evening. Actually, it's 8 p.m. in Ulaanbaatar, and thank you so much for organizing this event. Thank you so much, Michelle and ICI team. And thank you, Dr. Ganchimeg, for the opportunity. And today I will present our experiences of implementation of the 12 steps in our private maternity care hospital in Khurungal Hospital in Ulaanbaatar, Mongolia. My name is Munguntsetseg. I'm a pediatrician, neonatologist, and international board certified lactation consultant in this hospital. Here is the brief information introduction of our hospital. So our hospital was founded in 2010 in capital city of Ulaanbaatar, and we serve more than 150,000 patients each year. We are fully privately funded hospital. So we have 100-bed hospital and 3 outpatient clinics and with 7 departments. Currently, our hospital staffs with international, our hospital is the only hospital staffs with the international board certified lactation consultant in my country. And our mission is provide the best care and the service to every patient through evidence-based practice. And our vision is most trusted partner of healthcare and the family-centered, family-friendly care. And our most important value is the health and well-being and satisfaction of our patients. So this is the brief information about maternity care department of obstetrics and gynecology. We have 2 delivery rooms and 2 operation rooms. We have postpartum unit with 30 rooms, and we allow the families to stay during the birth and postpartum. There is some statistics of our department. We have approximately 100 births per month and 1,000 births per year, and C-section rate is the 37%. And currently, our human resources is 9 OBG doctors, 4 neonatologists, 1 board-certified lactation consultants, 10 midwives, and 10 pediatric nurses, and 8 doulas. And here are some samples of our national policy on maternal and child health. And we have very modern and baby-friendly policies from the government. For example, the first one is the law from the Parliament of Mongolian Parliament. Here is the nutrition, feeding love of infants. And the second one is essential newborn care, which includes the 10 steps of successful breastfeeding. Also, we have national program on maternal and child health. So our hospital started implementing the 12 steps since 2021. Here is the photo of the phase 1 certification from ICI, and we are really grateful for our certification. And here is our general director's order of implementation of 12 steps in our hospital. Now we have 12 certified doulas who has completed the course and certified as a doula, and 8 of them are midwives and 4 of them are assistant nurses. And now in our department, we have 8 doula and the midwives, full-time doula and midwives, and the 2 midwives work in a 1 shift, and 1 doula at the 1 shift. About 80% of all births accompanied with doula at this time. So we try to accompany and assist every delivery with doula. Here are some pictures and the photos of our doulas, amazing doulas in our hospital. And here are some pictures of, we have the monthly prenatal class for upcoming parents who's expecting their babies in our hospitals, instructed by the midwife doulas. And here is the how the class, prenatal class. It includes information about how the process, baby-friendly, mother-friendly, deliveries in our hospital. Also, it's about the breastfeeding. Also, it's about how to care the newborns. And here is the brochure of our prenatal classes. And we also do monthly and trainings and information sessions of 12 steps for our medical professionals. Here are some pictures of this medical information sessions. And also we have brochures for our patients about the 12 steps and about our maternity care. The first one is the paper printed brochure, and the second one is QR coded information. And the next one is the, yeah, I think it's a brochure also. There are some examples of the quality improvements of maternity care after we implemented the 12 steps in our hospitals. The first one is prenatal care notebooks for every mother who has in the prenatal care examinations in our hospital. The second one is comments and requests boxes. If they have something to say about our maternity care, they can write letters or comments and etc. And also we have the gift sets for our patients. And here are some pictures of the emergency obstetrics and neonatal sets in our hospital. And the current status of 12 steps in our hospital, we did not get any negative comments from our patients, the mothers and the and other staffs of our hospital. The mothers and the families are very satisfied. They're very feel very good about the doula care during their birth. And maternity staffs and other healthcare professionals also, they have very good attitudes and the good feelings about the 12 steps. And now we are collecting the QR code questionnaires from the mothers since this April. Thank you. Thank you so much.
Thank you. Thank you, Munguntsetseg. So I will share. Okay.
And we
Okay,
are
so
happy to answer questions on a Q&A session. Thank you on the discussion.
So next, I would like to present about the Mongolia, the public hospital that is implementing ICI 12-step and mainly focusing on the implementation. So there are two hospital steps from the hospital. Padma, do you have there? Padma, can you open your Padma? Okay, so there are the people from the Mongolia hospital. So I will present behalf of them. So this so this is the one of the Mongolia hospital, public hospital, maternity hospital, the capital city, and it covers about 24% of the capital city population, and it's about the 8,000 delivery annually, and 26% of the C-section rate. And for the maternity, for the each shift, about 5 to 2 OBGY and 1 neonatologist and midwife and 1 doula and 1 nurse assistant serving for women. And so this hospital is the first hospital that we implemented doula. So this one is started for, we conducted one quasi-experimental study to check to examine the feasibility doula support to a small group of women by midwifery student. And after successful, we introduced the birth doula workshop training to all the nurse assistants. And then since 2020, the hospital employed doulas, the 5 doulas, nurse assistant as a doula. and then continuously providing doula training and to other hospitals. So the first of all, I would like to just mention about how this doula project started in Mongolia. So this is the based on the first study that we checked the continuous support for small group of women by midwifery student, and that students are providing care to the in the labor room. One student provided doula support for 4 women, and the one student for delivery room. And then we also use it. Each student, doula student, had the doula bag that would make every smooth care. And this is the pictures how they provided care. So we use it to make sure that everyone knows that doula, instead of using doula as an English word, we use it the Mongolian word that is we always together, we always with you, like a bird companion, to make our mothers to aware about this service and doula. And then next, after the successfully conducting, and we also get the feedback from the hospital administration and doctors and midwives, that is, they appreciated it, and also the women's satisfaction was high. So we decided to implement this doula training to Mongolian. And first we trained midwife and nurse assistants. So in this picture, the nurse midwives, they providing the care, also they provided doula care. And then since 2020, the hospital first employed as a nurse assistant as a doula. And this is the 4 doulas as a becoming the full-time doula. And the, so this is also shows the labor and delivery award of that hospital. And this, they have a 3 labor and delivery room, private, and it includes the labor room and delivery room and the private rooms that can the family can come stay with the woman. And also they have the shared room, labor room, so which mean have 2 beds shared. And then after delivery, after they for the delivery, they will go transfer to the delivery room. And in this room, the woman not allowed to bring the family. So our doulas is exactly working with this woman. If there is no one given birth in this room, so doulas serve for the VIP room, the private room, and providing doula care. So this is the delivery room. And during this, the ICI implementation and the doulas program, the hospital enhanced their delivery rooms and then making privacy. So this is the picture. I'm sorry. Okay. So the pictures how our these doulas is working, and also there's social media people appreciating this doula support, and every woman wants support. So also this hospital providing childbirth education for women, and also they opened the child room when the woman come into the antenatal care, and they can bring their children. And also they're inviting other hospitals, they experience sharing. So there are 4 maternity big hospital in Ulaanbaatar, the capital city. So they come to this hospital to see how the doulas is working. And also the hospital sharing their the achievement for the academic journals, and also the clinical or the scientific research conferences. And here is the challenges they're facing, because it's not one-to-one doula. Some women have the less satisfaction, and also someone feels that they are discriminated because the doula need to care more the complicated or more painful women. And then if there are maybe 4 women delivering, so it's not enough for 4 of them. So then they might have some misunderstanding. And then they're trying to, it's difficult for the public hospital to make the one-to-one doula support, and that's because of human resource and budget limitations. Okay, okay, thank you so much for this listening. And we are happy to share and discuss about for the discussion section, Mongolian experience. Thank you, Michelle.
Thank you so much. And I think I didn't mention at the start, but the hospitals in Mongolia are two of the first hospitals that joined ICI. So you've been with us for a very long time. And I think it's really amazing the scope of what you have been doing. It's really fantastic.
Thank you.
I am going to call our next presenter. I just want to confirm who is up next. Just 1 second. I think we do have everybody here. Dr. Alex Mbuta, would you mind presenting as our next presenter?
Yes, please.
Okay, absolutely. From Thamini, Uhai. I'm really pleased to welcome Dr. Alex Mbuta. He's fantastic. They are new to ICI, Thamini Uhai, but I'm hoping that they are going to be joining with us very soon. They are working in Tanzania, and by coincidence, they utilized one of the doula trainers who also trained the team in Kenya that's going to present right after. So go ahead. I'll leave it to you to go ahead and introduce the organization.
Thank you so much. Good evening and good morning, everyone. I hope my presentation can be seen in presentation mode. Okay, so I'll just take you through our experience in implementation of birth companionship in Tanzania. So our organization is called Thamini Uhai, which is a local organization based in Tanzania. It was first known as Wedlang Foundation because of its affiliation with the International Wedlang Foundation and Vital Strategies. Later in 2016, we had a media campaign where we transformed our name from Wedlang Foundation to Thamini Uhai, which literally means value life. We were mostly concentrating on implementation of comprehensive emergency obstetric newborn care in few regions in Tanzania, especially Kigoma and Katavi. And then through thorough evaluation, we learned that respective maternity care is a key component of addressing quality of care. So our model used decentralization, task shifting, and creating demand. Decentralization by ensuring that the low-cadre facilities or hard-to-reach facilities could provide basic emergency services and comprehensive. Task shifting using the non-physician to provide complex obstetric emergency care. So we embarked on respective maternity care as a key component in our program. We all know the benefits of having a companion during birth, as said in the 12 steps. So our birth companionship program started in 2016, and it started as a pilot project in only 9 health facilities in Western Tanzania. We wanted to learn if introducing a birth companionship is possible in public health facilities, but also if it leads to improved birth outcomes and experience of care, and especially implementation of respective maternity care. So we had a general support from Bloomberg Philanthropies, Foundation HB and AGRU, and also Blue Lantern. And we used multi-stakeholder approach where we co-designed the birth companionship design, including the roles of birth companions, the types of birth companions, responsibilities, the do's and the don'ts, and also we engaged companions during the implementation. Now we had 2 types of companions. The first one was the on-call birth companion, the name which was designed by the co-designing meeting, and they were trained by the project. They were paid a stipend and airtime. They received a training thanks to Amadoma, who came to Tanzania. We had $3, 3 birth companions at each facility who had a shift of 8 hours. And these were stationed at the facilities, and women were given choice to choose to have them as a companion. The second time, we had a desired birth companion who were chosen by the mother or the pregnant mother from their social network, including their family member, friends, neighbors, and their partners. And these are oriented by the project through providers who are working at the antenatal care clinics that we are supporting. So what were the roles? The roles were, so the meeting that engaged stakeholders defined the roles of birth companions, the criteria for selection, but also defined the limitations for the birth companions to do or not to do. So during antenatal period, they supported early booking for mothers, identification of danger signs, preparation of individualized birth plan. During interpartum period, they supported preparation before birth, supporting mobility during labor, supporting also relaxation exercises, call for help to providers when needed. They relayed information and sometimes they needed to translate because some of the community members do not know Swahili well. And also they ensured comfort and encouragement to women during labor. During postpartum, they encouraged early breastfeeding, postnatal visits, and also identification of danger signs both for mother and the child. Now, let me draw your attention to our coverage so far. So the project now covers 3 regions, and it covers around, it covers 24 health facilities. Of these, we have 4 hospitals, and we have 20 health centers, but also we are supporting surrounding dispensaries that are around the catchment facilities, around 48 of them. In a year, we about 15,000 deliveries happens in these facilities with around 16,500 live births. But of these, around 12,000 women are delivering in these facilities with the support of a companion of choice. Now, what were the core project activities that are implemented through the Birth Companionship Project? So the first component, which is done, is infrastructure improvement. Our labor rooms do not have privacy. Most of them are just halls. So the renovation is done to make sure that we have audio and visual privacy for dignity. And also we develop job weights and guidance for the providers. We also support the training of the providers. And in this case, we are training them on how to help the companions to be able to care for mothers while they are there. We also work with community health workers to educate women through household visits, to inform them information about what are the criteria for a birth companion, how can they choose a companion, and what are the benefits of having a companion. We also build the awareness of the communities through outreaches, community health worker household visits, and media and media campaigns through the community. And then we conducted action-oriented feedback with the country management teams on quarterly basis. And also we conducted community scorecard for accountability. That community could have a meeting to discuss about what are the challenges of service provision and what do they suggest to improve more the services. So we also disseminated the information about the project through conferences within the country, and we had a component of quantitative and qualitative evaluation of the program, where we had key feedback from the community, and these are also explained here. Now, since we started the pilot, the project has evolved over time, and here are the things that we did as we learned from the evaluations to more improve the project. So first of all was shifting to the use of cost-effective desired birth companions more than the use of on-call birth companions who are supposed to be paid, to be trained, and to be sustained. And also we shifted now from the on-call birth companions to have a health care provider at the facility who would be trained on birth companionship and non-pain management techniques, and now will be called a focal person for the project within the facility. We also advocate for budget allocation using the government funds to ensure that they upgrade their facilities. We also added the aspect of accountability through implementation of community dialogue through community scorecard, but also we used the traditional birth attendants and the desired birth companions from the communities to form the association groups and have a skill training to improve their ability to generate income, but also to have something in common that will keep them together. But also we also established the community emergency scheme funds, and also we added a component of pain relief strategies where the 2 staff of the project were also trained as doulas and are now certified. Here are some pictures. You see the use of pen relief strategies during labor. And here is a happy father with a baby, and he acted as a male companion during the delivery process. So our project since pilot, we started with 9 facilities, but over the years, we increased the number of facilities from 9 to 13 in scale-up phase 1, then from 13 to 24 in scale-up phase 2, and now in phase 3, we went to 25 and now moved from 2 regions to 3 regions of implementation. Here is one of the areas where we renovated them for audio and visual privacy in one of the facilities, the public facilities. Now, what are the achievements that we learned from the implementation? First of all, the coverage was increased. We saw the increase of facility delivery and good utilization of companions. We saw the improvement in terms of respective care and positive childbirth experience, as the qualitative studies revealed the certification of women through interviews. Healthcare providers also reported reduced workload due to companions. A high community acceptance is seen, but the most important is now the country has a national guideline that allows implementation of birth companionship as one of the key intervention to address disrespect and abuse within the country. And lastly, we have a very strong political will where the president herself declared that it's important for women to have a companion during birth, as the launch of one of the big maternity wing which is built in the country, she declared that, which is a very positive political will from the country. Thank you so much, and I'll be happy to share anything else if needed. Thank you.
Thank you so much, Alex. That was fantastic. We're going to keep moving along just so we can get through our last presentation and then go to questions. So I'm going to ask Carren Siele to, Carren, if you want to go ahead and turn on your camera and share your screen. And I'm also going to put up a quick poll just to see who is here in the group as far as how many doulas, how many midwives, how many obstetricians, nurses, and physicians. If we've got you here, please respond to the poll. If you are watching this on the Facebook live stream, you can just type into the comments if you are any of those things or multiple of those things, so we can see who's with us today. Carren?
Yeah, good morning, good afternoon from Kenya. My name is Carren Siele. I work for Lwala Community Alliance based in Kenya. It's one of the birthing centers which is implementing the 12 steps of ICI. Lwala is currently supporting, 2 facilities. That is Lwala Birthing Center and also Minyanya Birthing Center. So allow me to share my screen.
It looks like we have midwives in the lead.
Yeah, thank you so much. So I said I work for Lwala Community Alliance, and I'm so grateful for this afternoon here in Kenya to join the doulas and to cheer up the work that doulas are doing to support our women globally. With me, I'm joined by Lwala doulas. If they can turn out their screen so that we can be able to see them, as we appreciate the work that they are doing in Lwala and supporting women within our communities. So our project for ICI began in 2020 when we were doing a lot of discussion together with Michelle, but the actual implementation began in 2022 when we trained the first cohort of clinician and midwife on the 12 steps of ICI. And there have been a lot of implementation. In 2023, we moved forward to support to train doulas who are coming in to support the women in our maternity. So Lwala is basically an organization supporting communities. It's based in the communities and supporting women. Our core main implementation is to support women to ensure respectful maternity care, to ensure women delivering safely, they're protected, and of course to ensure babies being born are actually able to survive. So we have 99% of all our skill births attended by skilled healthcare provider, and basically these are midwives working in the maternity. And of course, last year we were able to introduce the doulas to continue supporting the work that midwives are doing. So In partnership with the ICI Phase 1, we trained a team of clinicians, 20 nurses, together with a clinician. And in 2023, August, we trained 24 participants. And we were looking in terms of resources who were actually people to be trained. And one of our things was to train our patient attendants who worked in the facilities, to train a few midwives, just so that they are able to understand the work that doulas are doing in the maternity. And also we incorporated our community health promoters, our community health workers, who were initially traditional birth attendants, to come to the facility so that they can be able to support the women. So the training took 1 week, and this was supported by donor international curriculum. We had our international trainers, and also our trainer from Kenya, our only trainer, Esther Kimani. So before doula training, we were looking in terms of how best can we advocate, for women to continue receiving quality care, antenatal care, and including the childbirth. So patient attendants, their role, we were looking in terms of modifying their roles. They were basically, doing only advocating, health education, but we wanted to bring them in touch so that they are closer to the women. Apart from advocating, talking to them, we wanted to create that linkage so that they can be able to even accompany women during childbirth, and also to get the skills and to ensure they will continue to provide psychological care. And of course, they were maintaining hospital general cleanliness, ensuring the areas within the maternity are safe for women. And the role of the CAW, we also had to motivate, because initially the CAW community health workers used to work in the communities, but we wanted to bring them to the hospital to support the women. So we trained them to come in, because they already had some skills. So we wanted to bring the doula skills so that they come to the hospital. As much as they are advocating in the communities, they can be able to also support that role within our birthing center. So we met together with the support of Michelle and our leadership for the hospital, and we decided to modify to capacity build, and also to bring them to the hospital for the training. So we have 2 birthing centers, that is Lwala Community Alliance Hospital, and also Minyanya Hospital, which is also a government-based facility. So the trainers the participants were selected, and then they began, pre-training, watching videos 2 weeks prior to the training. Then the training began, and the donor international, were trained using the certified curriculum. So they began supporting women, during pregnancy, before pregnancy, during pregnancy, during labor and childbirth, and also providing support during postpartum care in the hospitals and also in the community level. And this was actually to build them, to provide women to transition so well during postpartum period, because many things happen during postpartum. Midwife have done deliveries, but we wanted to ensure this is also moving to continue supporting them even as they move home, to incorporate with their families, to continue breastfeeding, so that it makes them easier for them to continue breastfeeding. And this has actually yielded a lot of results. Initially we used to have women coming back to the hospital with mastitis, unable to breastfeed, but doula coming in to provide that information fully to the women, and to continue supporting women in the hospital postpartum, and even doing community follow-up, especially for the CAW who are actually working within the communities. They were able to do that role so well and to support the women. So so in terms of scheduling the doulas, the 2 hospitals are able to function 24 hours. We have a doulas covering during the day and doulas covering during the night. And of course, through the training, we also decided, to modify our labor. Before you engage into your training, you will always go to your labor room and you think it's the best. But when someone from, externally come in and see your labor with a lot of skills in terms of doula role and ICI, we decided to expand some spaces, to create some spaces for postnatal, and also to reorganize our delivery room so that we could get space for women to move around, to play with the birthing balls. And then after training, we also incorporated other people, orienting the healthcare providers, that is the midwife, the nurses and other cadres working in the hospital, so that they are aware of what is the role of the doulas, so that they are able to support the doulas. Because initially you hear about the conflicts between a midwife and the nurse. So we wanted to ensure everyone actually understand the role of the doulas and how they are working, so that they can be able to support, as doulas are supporting the midwives or the other staffs working in the maternity, then they can also be able to be supported so that they can excel in their role. We also oriented the midwives on the birthing positions. Initially, we used to have one birthing position, which is, of course, very comfortable to the midwives. So midwives could be standing and, supporting births. But now we are bringing in, like, women needs to be educated. Women needs to be given, information about the position that they wish to give birth to, because it's only women who understand the birthing position. But for the midwives, they are giving, like, you need to sleep in the lithotomy position facing up. No. So we've had our midwives, supporting women, giving information, and ensuring, women are delivering in the position that they wish to deliver. So one of these pictures is showing our doulas during one of our sessions. We call it Maternity Open Day. That happens on after every 2 weeks. Women are booked to come in together. All the pregnant women, they come to the facility, get to interact with the doulas. Doulas are teaching them, providing a lot of information. And by the way, doulas have a lot of information when it's come to teaching women. And they're actually very patient, with women, unlike the other cadres where, you have a lot of patience waiting for you. But for the doulas, they actually take their time, support women, teach them the birthing position, teach them how to play the ball, and of course incorporating their partners' male involvement. And we've seen through the doula work, men are able to come to the antenatal care to support their women, and also come in to support women during a childbirth process. And one of the areas, my favorite doula, doing what she likes most, supporting women. And when you see the face, it's actually, they are very smiling, they do the work with a lot of passion. So, and in 2023, September, after the training, we did a lot of orientation, community orientation, sensitization on the role of doulas through Maternity Open Day, where forums where women meet together. And of course, I talk about, modifying our space, creating our space. And then we purchased the birthing tools for the women to continue supporting the women. And then, of course, documenting a lot of success stories, checking on our data. And actually, we realized our number of referral is actually, we've cut a lot of referral to higher facility because we don't have theater. So we are able to cut our referral costs. Women are now giving birth because they are supported. And of course, integrating childbirth classes and conducting also review meeting with the doulas, where midwives, doulas, they're brought together and they are done, they are reviewing what they are doing and reviewing the progress. So we also started doing ICI questionnaires to mothers, just to get feedback on how they are cared for during maternity childbirth. So why was this assessment very important? One thing is to gauge the quality of maternity services and to check on the engagement between mothers and the healthcare providers during childbirth process. And we learned that, booking women, having childbirth classes for women is very, very important, because women get to understand about, pregnancy journey, get to understand how to take care of the babies. And it's also improved communication between the mothers, and, they're able to choose the birthing position, and also orienting the healthcare providers on the birthing position actually help, because women are able to choose the birthing position they have. And then, of course, the importance of having doula to support mothers in maternity. So we have a lot of success stories where women are sharing with us in our social media, and also one-on-one, and also through engagement. And allow me to take 1 minute just to explain one of the story that we were able to share was about this doula, Dorothy, who was able to provide support to these women. And the engagement began during Maternity Open Day, and the client just felt in love. I don't know how to say involved, but get really connected to the doula, and then ask the doula, I want, when I come to the hospital to give birth, I want to spend time with you. So when this woman, felt labor, he was able to call the doula directly and ask her to come and come into the hospital, kindly ensure you take care of me. So the woman was taken care so well. And she was able to appreciate, the doula, appreciate, the presence of the doula during pregnancy and during childbirth, and also the continuity of supporting families at the community level. So the doulas, this is one of our doula working in our partner facility. You know, apart from even spending time in the community because of their other role in terms of community service, so they spend a lot of time teaching women in the communities about childbirth, advocating for the women, and providing that continued support from the hospital to the community level. Thank you so much, Michelle, for the opportunity.
Oh, fantastic. Carren, don't stop sharing your screen. Do you mind to go back to the one of the Open Maternity Day? Can you play the video so that they can see the movement? Let's go here. I think, oh yes, it'll let me play. I like how they did the demonstration, and then I think this one as well.
Lipabe. Mesema nita anti ya kusaidia kutembea. Kwa nini?
And we also have Esther. So the training, the doula training, as Carren mentioned, was done by Amadoma Bediaku, who did the training for Thamini Uhai as well, along with Esther Kimani. And Esther, unfortunately, Amadoma is not with us today, but Esther is. So I wanted to invite Esther to kick off our discussion by telling us a little bit about her background and experience, and then we will move on to open it up to everyone to share their experiences and questions. Thank you so much, Carren. I know we're going to have questions for you as well.
Good afternoon, good morning, good evening to everyone. My name is Esther Kimani. I am a doula. I've been practicing for the last 14 years. Certified doula by Donor International, and almost finishing my paperwork to be a donor trainer. But I'm also a Lamaze trainer. I teach people to teach childbirth classes. And basically, I've been practicing mostly in my country, Kenya. And for a long time, it was even difficult when you say you're a doula. People are like, "What's that? What do you mean?" But we are slowly seeing inroads to that support. A lot of times, the support is in the private sector. But one of the things that happened maybe a few years back is that one doula got into it with one big private hospital, and that private hospital went on to really make it really hard for us to work. They wrote to the other hospitals, but we're slowly seeing the birthing people really saying that we need to have doulas with us. So there are some hospitals that allow us to actually go back and practice. We do support during home births. In Kenya, midwives are allowed to do home births, run home births, and so we support in terms of home births, and really excited to facilities like Lwala and some of the other smaller facilities that are incorporating doulas into their maternal care practices. So I have been trained before becoming a donor trainer, which I'm about to finish and become a fully certified donor trainer. There was nothing to do. We needed to train the doulas. So I did come up with a curriculum that I was using just to be able to equip people to be able to support and give this support to the birthing people so that they feel respected, they feel supported. My country is very family oriented. So we have a lot of support from your family, from your mother, your sister, the women in your family. But we are slowly seeing also the male partners coming in and coming into the fold in terms of support. But it's still not enough, because a lot of times doulas are trained birth support companions. We see people going and they don't know what to do. At some point, they panic alongside the birthing person, and so it becomes really difficult for that mother to say that I really had a good experience. Some of them, I remember one saying, the reason I wanted doula is because with my first birth, my partner fainted and cracked his skull. So there's all these things that happen. So a doula has a space to offer that respectful and supportive maternal care. So in Kenya, we are really proud of Lwala, because Lwala is showing us that it can be done. Because a lot of times the public sector says that, oh, we can't have, our rooms are too small. Same, I think Dr. Alex talked about it in Tanzania. Most of our maternity, it's a maternity room. It's not rooms, it's a big hall with beds, sometimes with curtains, sometimes not. So there's no privacy. And so most times when you go there, they're like, we can't allow outside people because we don't have space. But when we have doulas incorporated into the same practice, then it means that these mothers can come and have their babies being supported, even in whichever space that is there in terms of what we have. But also making people think. I think I remember talking with Carren, like, how can we modify this space that you have? We don't have to build a new space. We can work with what we have, modify it to make it work for everyone. And it's working. So it's a model for us that can be replicated across the country to show that we can actually make it work in whichever aspect we have. All we need is to train more birth companions so that anyone who's coming to the hospital, a doula for every birthing person that needs one. Anyone who needs that birthing companionship should be able to come and have that companionship in the hospital, whether they come with someone they prefer or they come into the hospital and they're finding people who are waiting for them, waiting to support them. Part of the big factor, and I think hearing people from Mongolia, from Tanzania, and from Kenya, one of the things that we really have had to do is adapt the curricula. I remember when Amadoma came, Amadoma is the one who was doing the training, is we have to sit down and say, this is the curriculum that's there. But some of it doesn't, I mean, we do not have epidurals in Lwala, and neither do we have it in most of our country. The ways that we have, the way that we birth our babies is very different from some other country. So I think it's important, even as we are working to train our birth companions, that we just don't take the curriculum, but we take the curriculum and modify it so that it works. Otherwise, we'll be hearing stories that it's not working, or then there's conflict between what's the government saying about the maternal care, and then you come and bring something different. Then we're going to have that strife. But when we modify it so that it works for our setups, then I think that makes it really, really much more adaptable, and it will be used by people, and it will be easier to actually get inroads. So for me, I really, really, really pray that every hospital represented here would have birth companions, that every birthing person that walks into a hospital will walk in with that support that's there, whether it's their partners that at least have had childbirth education classes, or the doulas that are in the hospital or coming with them to be able to support them. Thank you so much, Michelle, for this opportunity to just, start off the discussion.
Thank you, Esther. I think it's great to have you here. And so I wanted to start with one of the questions, but then I know we have so many people here with different experiences. So if you are ready to talk, put up your hand and we'll switch over to you. Oh, also to just give you the feedback from the poll. Let me go back and find it. We have with us today, it was even 36% midwives, 36% doulas, 14% obstetricians, 17% nurses, and 8% physicians. So a nice mixture of people with us. And I wanted to, I wanted to speak about the question that Dr. Bangal put into the chat about the cost, because I think it was really helpful to hear from Mongolia and from Tanzania that the cost has been a barrier or a limitation. I think it's especially helpful since Kenya is early on, and I know, Carren, you're already having discussions with the government. They're really keen to start scaling up across Migori County. And I think there is a question of what is that going to look like financially? So it's helpful to have a sense of that. So I don't know if any of the teams would like to speak further about the cost as an issue and a limitation to the number of doulas that can be available. Yes, Dr. Domenico, please go ahead.
Thank you. Thank you very much, Michelle, for this opportunity. I'm Domenico Sande, OBGYN, Director of Program at Thamini Uhai, and also the President-elect of Association of OBGYN in Tanzania. So again, it's a wonderful opportunity to be part of this great webinar. When it comes to sustainability of interventions in low middle-income countries, of course, cost is an issue. And when we were designing this program initially, because it's something new in local context, and we really wanted, we targeted at least 50% of women who are coming to the facilities to have an opportunity to choose the companion of their own. And so beyond what Dr. Alex has presented, we really had to continue sensitizing community, but also identify birth companion that would be available at the facility for those who would not get information, maybe in the sensitization in the meeting that we conduct. And this is what we call the on-call birth companions. And in this particular point, the project had to take care of the cost, which was real, mostly the subsistence cost, which in dollars, it was about $40 in a month, which real was not a big burden for the project. And once the pilot phase came to an end, now we phased off the on-call birth companions, and we just maintained the one who are coming from the social cycles of pregnant women, and these we call them the desired birth companions. So the desired birth companion has been the mainstay of the program for the previous 4 years since we ended the pilot phase. And so the cost from major cost for implementation of this now remains on the renovations because of the nature of the labor rooms in Tanzania. So we really have to continue investing on renovation of the labor rooms and also community sensitization, so that more and more communities and the women would opt for birth companions as something new trainings for the healthcare providers and the like. But if you compare the cost that is entered and other interventions that are done on the same settings, because we had also experience of doing emergency obstetric and newborn care, this is quite less in terms of how much you invest and the results that you get. So we wish to continue doing this work and ensuring that more and more women can have the experience, which it need is a minimum that they need in that process of pregnancy and childbirth. Thank you, Michelle, and I would be able to come back if any point to lead further discussion.
Thank you so much, Dr. Domenico. I think, was there a follow-up question? Okay. This is a follow-up to either of you from Thamini Uhai. Do the on-call doulas meet the women during pregnancy or when they were there, or did they just meet when the woman had gone into labor? And actually, that might be the same in Mongolia. Sorry, go ahead.
Thank you very much. So on behalf of the team, the on-call birth companions, this is the team that was lucky to be trained by Amadoma as the doulas, and they were stationed basically at the facilities. So the first point that they would encounter pregnant women, it was during the antenatal clinics, where they would have an opportunity to sensitize and give education to women on birth companions. And then the second opportunity was when these women were coming now for delivery, when they're in labor. And that's where they would give them option. Would you choose me? Or if not, then the pregnant woman would opt for the desired birth companion in that particular sense. Or very few would opt to, because something new, they would opt to just go in without any companion in that process. So that's what was happening with on-call BCs. Thank you.
Thank you, Dr. Domenico. I'm just
Can
going.
I go ahead on this question?
Yes, please go ahead.
The last one. Thank you. So if the mothers, the prenatal classes, it's a voluntarily if they choose to participate in these classes. So they will be meet their doulas during the classes. So they will be meet in a second time when they come to the maternity homes, the hospitals. So if they are not participate in the classes, they will be, meet there in the first time during the maternity care. Thank you for the question.
Thank you. I wanted to.
So in Mongolia, like we have a different doula type. So about 80% of the deliveries occur in the public hospitals. So compared to the private hospitals, we are so crowded in the public hospitals. And then it would be difficult to provide one-to-one doula. So we decided to have the one doula providing for the group of women doulas. So in our cases, because there was the nurse assistant already there, but we just shifted their duty and make with. So for the hiring, the doula, so for the cost wise, it was not too much burden to the hospitals. So in the capital city, there are 5 hospitals, and 3 of them already implemented the doula as a nurse assistant as a doula. For the private hospital, because they have very few, slightly limited the delivery, so the woman can bring family and then also have a plus the nurse doulas accepted there. So this is the not additional cost for women. So that is the one way we succeeding. And another one is there's another Mongolian the doula associations, which is training for doulas, which is they can do the business oriented. And nowadays every hospitals and maternity hospital medical doctors and medical staffs that know about doula, and some of them is allowed to bring doula person who is already trained as a business-oriented doula. So that's just one advantage. But we only focusing on the capital city, so we not sure about how we can do it for the rural areas. So but majority of the 50% of our population residing in the capital city. So we believe that we half of the women who live in our country are kind of knows about doula, but we are aiming to kind of one-to-one doula, but it could be more costly. So that's another challenge we are going to step up. Yeah, thank you.
Thank you, Ghana. I hadn't realized how massive your initial training was and how many locations you had covered. That was actually going to be one of my questions. It's kind of incredible. So maybe we'll come back. I want to let some of the other folks speak, but if we have time, I want to come back to that. Aditi, would you like to unmute? And then anyone else, please put up your hands and we'll go around. If you even if you just have comments and want to share your experience where you are.
Sure, Michelle, and hello everyone, and thank you. So I'm associated with Africa Midwifery Center, which is a specialized, maternity center in Bangalore, India. The model of care that we follow in Africa is essentially it is the mother-centric midwifery model of care. So more than doulas, we have in-house midwives who are present as part of our staff at Africa. And we have, and it's a collaborative model with OBGYNs, with midwives, with the neonatologists and pediatrician, as well as nurses. Along with that, what we encourage, and we have it as part of our officially stated policies, we encourage all mothers to have a birth companion. So all mothers are encouraged to have a birth companion, whether it's a family member, friend, or whoever they're comfortable with. Some mothers also bring in doulas. So what we, and when we realized that, what we also did is we actually work with a lot of professional doulas in Bangalore. I think there are around 5 of them that we work with, and 4 of them have actually attended births, at Astrika. Now, for all our births, we have birth companions present, but I think for doulas, the percentage currently is around 10%, or I mean, around, so. We became an ICI facility very recently. In fact, it was middle of last year, and we're still in the process of figuring how the ICI works and what we need to do. And Michelle has been a great help in that whole journey. But and this is like the first webinar that we are attending. So it's very informative for us to realize and understand how different facilities across the globe function. We are a private facility, but we also have a sister, concern, which works in the public maternal health space. And a lot of what, the different participants mentioned really resonated with us, because we see a lot of similar challenges with acceptance, with changing of mindsets and things like that. And Astrika Midwifery Center essentially is sort of a place where we want to show how midwifery can work as a model of care, and it's just, you just don't have to have doctors and C-sections as the first resort rather than the last resort. So, like we're saying, we work with a lot of doulas. We have, in fact, as part of our ICI committee, we have a doula as a member there, as the external member there. We have a lot of IG lives. We have a lot of discussions. We work with, someone known as Jenny Koslow, who is also a doula and part of the Previda organization. And she's come and I had multiple workshops, one for birth workers and doctors, and one for to-be parents on birth communication and, what to expect during a delivery and things like that. And so like we said, we also encourage student doulas to come visit and see our facilities and see how, we function and work. And we encourage mothers to also reach out to doulas if necessary.
Thank you, Aditi.
Thanks,
you made a good point, which it is technically also part of step 4 is one-to-one midwifery care. And we didn't highlight it during this session, but I think that because I think in many of our sites or many places around the world, that's aspirational and we're not there yet. So I think that's very often where the doulas come in, to help close that gap. So I really appreciate you talking about the midwifery care at Astrika.
Sure. Thanks.
I want to go ahead and call on, people are still joining. All right. I want to call on the doulas from Lwala Community Alliance, Maruka, Rosemary, and Winfrida to say hello and to give their comments. And then I'm going to go to Dr. Bangal. And then anyone else, go ahead and put your hand up if you'd like to speak next.
It's Rosemary, doula from Lwala. It has always been a fantastic time since we came from the training, and we are really happy for our doulas in Lwala because they have done a fantastic work. This has reduced the maternal deaths. We don't have more referrals, no post-hemorrhage, and now the clients are really at ease when they're laboring, during their laboring session. This is really making them have an easy time at their labor time. And this one is really encouraging because we don't have more maternal death, no referrals, and it's really a good time. And there's more delivery. We have more deliveries in the hospital than the community, and now the families are really happy, and they are really suggesting that we have more companions and we have friends at the community level. After the births, we also have home visits for them to do health talk on attachment of babies to breast to their mothers. This is making them learn more how to breastfeed their babies, and this is so much encouraging. We have a lot of mothers delivering in the hospitals, and the numbers are really high compared to last times that we never have doulas. I have my companions, other doulas here with me, and they also like to share with you. Thank you.
Okay, thank you so much. And nice to meet you guys today to share our work as doulas in Kenya. My name is Millicent Miruka. I'm a birth companion from Lwala Community Alliance in Kenya. So far, I can say that we as doulas, we usually offer the physical support during labor pains to these mothers. And so far, as my colleague has said, we really appreciate, and even the work of doulas, we really get more clients nowadays in the facility, and they are very happy with us. So far, it is a good project, and let us continue with it. Thank you.
And it's okay with us because we are talking to us in Lwala, we are doulas, and we're happy to hear from you in this side of Migori, Kenya, where we have our doulas preparing to hear what you have for us. I'm Wilfrida, and I'm a doula in Lwala, linked to Lwala facility, and I've been working since September after our trainings. What I've been realizing since I started is that all the delivering mothers that we've been working with or we've been practicing with, they don't have perinatal tears. They are not stitched because when they deliver, the exercise that we do good, open the area that the diameter is well done, and the delivery is always done in a better way. So the other thing is that the primees, those who have never delivered, so when they come, they are really worried, but we prepare them before, because we do have the open maternity days. We talk to them and they become aware of what might happen in future. So when they come in for delivery, when they are laboring, they are not shocked. And even when they find the male doctors in the laboring room, they feel free and they come stress-free because we are there with them. We assure them that I'm going to be with you till everything goes right. I'm here with you as a birth companion. We will be with you until the last moment. So they feel that they are well taken care of. So most of them do open up very quickly so that they could be helped in future. So we are really happy as we've been trained as doulas, and also the prolonged labor. I can't forget that. Those who come and agree to do what we tell them, they really deliver in some few hours. And they say thank you, because one can open up and tell you that since then, she had to give birth in 4 hours, 3 days, 5 days. But when they come to us and do the exercises with them together, they really find it that the labor is now shortened. So we are happy to do this because even the community members really adapt this and they come. If we now compare the number of men who come to when the women come to deliver, they really like the company, their wives. They are the first people to come with them. If we compare the number of men who come to antenatal visits and that who come to doula meetings, they are more than. So we are really happy because the community members really appreciate this, and the men that come in, women also come to now feel to come to Lwala, because it's only Lwala that we have doulas in Kenya, I think so. So most of them really come to Lwala and they appreciate, and they now like the work we are doing there. And we too, we really find it easy because the exercise that we do really help us as old women and all doulas. We don't feel all tired on all that. We feel that we're flexible. We can talk to our clients well. They open up, they see that we are together with them and we are a partner. So thank you very much, and let not doula program and trainings fall away, but let it exist all over Kenya. Thank you.
Okay, thank you so much. Let me add on something that has been left out. Okay, I can say that our nurses' workload has really reduced nowadays because we are there as doulas to support them. Thank you so much.
This is so fantastic to hear. I don't know if anyone else would like to comment. I know Dr. Bengal has some questions, so I was going to call on you, Dr. Bengal, unless someone wanted to speak directly to the fantastic Lwala team.
Michelle, this is Dr. Shuchi from Sevagram. Yeah, ma'am could not join because she was busy. So, we have been into Birth Companion for the last 4 years, and we've had real good results. Doula as a concept in India has not really been so, acceptable in the rural area, probably because of the financial implications. But the Birth Companion part has really shown very good results. It has decreased the number of cesarean deliveries. It has, improved the maternal and neonatal outcome. And they are a big help to us because, they sort of help us indirectly in laboring, in monitoring the patient, the laboring women, and telling us, sometimes, that things have progressed and all. And they are a big support to the women in labor. And we have had a real good experience in our labor room. And we have the midwives also. We are running this national training center since last almost 18 months. And we're doing all the alternate birthing positions, and we've got excellent results. Poonam ma'am couldn't make it, so I thought we'll share it with you. So the Birth Companion is almost 4 years, we are into it, and we've got real good results with it. So it is certainly a good initiative, and I think it should be taken up. Yeah.
Thank you so much. Dr. Bangal, did you want to go ahead?
Yeah. Good evening, everyone. I'm Dr. Bangal. I'm Professor and Head, Department of Obstetrics and Gynecology. Ours is a very quite busy maternity unit with almost 900 to 1,000 deliveries per month. So approximately 25 to 30 deliveries happening in the labor room, of which C-section rate is around 30 to 33%. A lot of high-risk pregnancies being referred to our unit because of all the facilities under one roof. I'm very happy that ICI has started this particular initiative of a webinar, which is a great opportunity for all of us to share our experiences. And it's always good to have learning from others, which has happened today. As far as Dr. Suchi, we have worked together, and I have similar experiences, what she has already narrated. In India, we have labor companion concept implemented because government came to conclusion that yes, labor companion is must, and since last 4 years, government made it a policy that labor companions must be there in the all delivery rooms. So all the first degree relatives, that is desired member of the family, is usually a labor companion. Initially, there was a lot of resistance from the nurses, from the doctors. They thought that it's a hindrance. It is causing overcrowding. It is interfering with their decision making and treatment. And also they had a thought process that it may cause infection in the labor room. But at my place, many things happened, which ultimately helped us in implementing this labor companion program. So once it happened that there was a baby swapping, then there was mistreatment by some a nurse or doctor, and there were a lot of allegations because there was no labor companion that time. There were unexplained stillbirths. Usually we have a policy that we show the sex of the baby to the mother so that there is no subsequent problem. As I said, it's a very busy labor room. 25 every now and then the babies are being delivered. So there is all the possibility that baby swapping may happen. And manpower shortage is always a problem because of this. So with all these problems faced by the team, they also came to conclusion that if there is an extra member from the family in the delivery room as well as labor room, it will help the team to sort out these problems. So there was a lot of acceptance, and plus government came with the policy that it must be there. Now we have a compulsory labor companion. She is there from very early stages of labor till the baby is handed over. She is even going to newborn corner when the baby is being taken care of, and all those problems related to baby has almost disappeared. It has also reduced verbal abuse. It has helped nurse to have some additional manpower. There is no baby swapping, no sex change, and as we have started initiating the early initiation of breastfeeding, breast crawl and all. So the presence of a labor companion is helping us to hold the baby in that busy labor room. So overall, the labor companion is helping us a lot. Now ours is a university hospital, I am very much in process of starting a doula program. That's why I'm asking for the program details, which I'm in position to implement doula training program, which is a short duration training, I think, and that will further help us in improving quality of care. Thank you very much.
Yeah, I think it's good to have the questions about the doula training curriculum. I think, and I can see in the comments back to you, you can see that there's answers that go from 3 days to a year. There's really a range, and I don't think there's any sort of strict definition of what is the minimum for a doula training. It's different based on the program. And I think that we actually, if there's enough interest, and I think there may be, we could perhaps have a full session just to have people come and bring their curricula and to talk about what's included, how long is it, what's working well, and all of this, because I think it's quite helpful to share. Does anyone want to comment about the curriculum, the training, the other requirements besides just the direct learning sessions? Oh, Gladys, did you want to speak, or you're just unmuted? I think maybe while we're waiting, Deborah, would you like to share any comments as we're going through?
My heart is just full of gratitude for all the presenters, just incredible presentations. So thank you all. Thank you for your teams that are here and supportive, and for everyone that's joining in and sharing what you're doing or what you're aspiring to do. I think this really touched me. I hope that it did all of you to come together today and see the work that people are doing to collaborate and implement doulas and continuous companionship in labor. I want to thank again Ray and Mary, Mary's not here with us, and Michelle, who have done so much work to bring these webinars together, and others from the IMBCO board and the ICI executive committee that aren't here today. But I also love the idea, Michelle, if people are open. I think there are many of us that teach doulas here, and I think we could collaborate on a session to give you all some ideas of how doula training programs are, to inspire others that are in the stage of wanting to put something together. So maybe that can be a next step of everybody here that does have a doula training program, if we can kind of come together and put something together for all of you.
Sorry, I'm muted. I think that would be fantastic. I do realize we're at an hour and a half. I'm sorry, I was kind of having fun and not minding the time. I think this has been a really productive session. I want to let everyone know that we are planning to continue having webinars every other week at the same time. If this works well for the majority of people, I think that we've gotten people across a lot of time zones. So mark your calendar, and if you've registered for this meeting, we'll send out an invitation. You'll have to register again for the next one, but it would be on April 24th. Tentatively, I believe that session will be with Dr. Vijaya Krishnan on slow labor progress, which is a very interactive session that she does. She did it a few years ago, and it's very popular and I think very helpful for people to talk about how to promote physiological birth when women are having challenges. And then we have a whole series that we'll send out the list. We're still finalizing some of the sessions, but every other week or so, we're going to bring everyone together. So I hope you can come back. Sarah Hinton, I just want to ask, were there questions or comments that we really didn't cover? I think I might have forgotten something. People are still joining. I feel terrible to end it. We have people.
I'll put all the questions in the chat just for quick access. I think the ones that didn't get addressed were mostly about the curriculum. The Tanzania team was asked about costs, the availability of the slides, which they'll be available. Maybe you could tell people a little bit about where to find that.
So for everyone, if you want to come back to this recording, we will put this recording on our YouTube channel. So if you search on YouTube for International Childbirth Initiative, it should be linked from our website. So you can go there. We will have the recording up in the next few days. We will put these slides on the ICI website, which is a bit in transition, but we will have them. And I think I can email out a link to everyone who's registered with a link to the recording and the where the slides are located on the website. Let me see here. I think I wish gosh, I feel like we could keep going. I really appreciate that some of the speakers touched on the conflict between the various types of providers, between the nurses and midwives, and the potential conflict with the between the doulas and the facility teams. I think it's a really important thing to talk about and to think about, because I think that is an ongoing challenge in most settings. I don't know if anyone would like to make any other comments about that. Because I just got this comment from a friend who had gotten a doula that her provider, her obstetrician said, well, that's going to be a third opinion. And I think that all the doulas in here would say that they are there to not put their opinions forward. And I think that that's just an obstetrician who had a negative experience, or just, one doula who just was not, sort of following that principle. I think that there is a lot of misinformation still out there about what doulas are and are not supposed to do. And I think it's really worth keeping this conversation moving forward. Does anyone have any comments? Ray, are you able to unmute? I know you were having trouble.
From Mongolian side.
Yes, go ahead.
So just before they start into doula program, we this was for the PhD dissertation. So we read a lot about what this child could be, what kind of challenges could be, and to overcome this kind of conflict between the health provider and doula, we had some strategies. The first one, we wanted to include all hospital staffs to given some scientific evidence, and also what doulas can do. And we having this for all the workshop for all staffs. So, and then when we trained the doula, so that would very collaborate with each other, because the OBGYNs and midwives, they already knows what is the doula's role and what can doula do, what cannot do. So it was in the beginning, it's very clear the duties and the roles. And then with our studies, so we didn't find any, we didn't, no one is reported about any conflict with the doula and medical of the professionals. So I think that's the our hint. So we had the 3 stages of this doula program: training, the introduction to the all hospitals, staffs, and also administrations. And then we also work at this the labor and delivery award, the VGYs. And then also we train for our undergraduate students also. So, and we gradually do that. So that's we have our strategy was. And also for the even others, exactly when we train for doula, we train the nurse assistants because they already work in the hospital. So if we train the doulas and bring into the hospital, that might have some kind of conflict, but maybe it's different by the country and hospital situations. We recruited doula from the hospital staff, so maybe they have some the good sides, advantages and disadvantages because they inside working inside. So some mothers may feel some different feelings. So, but I think the beginning, like ours, is it's not 1-to-1, but still we have been progressing. Thank you.
So Deborah has, Carren, yes, I'm going to just read Deborah's comment and then you can speak. So Deborah's asking for everyone who does train doulas, if you would message us if you'd like to put together an overview of curriculum with us and doula training for another webinar. Carren, go ahead. Also,
Yeah, thank you.
sorry. Oh, no, sorry. I'm gonna say if you put it in the chat, I will follow up and maybe send out a group message to everyone. So just say yes to Deborah's comment in the chat if you're still here. Go ahead, Carren.
Thank you so much. I also wanted to share experience back in Kenya when we were introducing the doula curriculum. So before the training, we were asking ourselves what are the role of the doulas and what is the difference between a doula and a midwife. So we got to train. So we decided to train the doulas and also train maternity midwives. So we picked a few representation of maternity midwife from the two birthing centers so that they could be able to train together with the doulas and get to understand what is the role of the doulas. So when we came back to the hospitals or birthing center after the training, then we were able to do all-site orientations to our team in different departments. So during the all-site orientation, we gave a continuous medical education, and also we were able to reach out to different departments to help them understand, because one of the things was the hospital staff needs to understand the role of the doulas so that they can be able to support the doulas as much as doulas are going to support the birth companion. So during the implementation phase for the first months, it was very, very exciting because the midwife really got to acknowledge that the role of the doulas is not so much related to the midwives, because the midwife will give medication, do examination to the vital signs. But, there was a gap in terms of who is supporting women, who is providing that physical presence, psychological, emotional presence, and even, supporting women to move around, because in working in a middle income countries where, starving is also a challenge. So you have one midwife supporting like 10 mothers, alone. So it is a lot of exhaustion. So this hand was coming in to support the role that, the midwives are doing, but it was a clear, there was a clear role for each, the midwife and also for the doulas. And when we were doing the survey in December, the midwife acknowledged that, the doulas are actually playing a lot of roles when it comes to psychological care that the midwives are not able to provide because of the workload, because of other demands when it comes to providing, medical management for the mothers. So it was different, and there was a lot of co-creation, working together and supporting women. So as they work in maternity, the midwife is not in charge. Of course, they oversee what the doula are doing, but their role are actually well differentiated. Everyone knows what he's doing at the different times. And of course, doulas, championing the rights of the women, because some women initially they were reporting of being abused, but in the presence of the doula, no woman is actually being verbally abused or even, being told a word that is not pleasant to the women. So doulas are playing a critical role that in case there's a conflict in other birthing center, then the healthcare providers needs to be brought together and clearly, explained what is the role of the doulas in supporting women in the birthing centers. Thank you.
Thank you, Carren. So we are at an hour and 45 minutes, which I think was longer than we had planned to go. So I want to reassure you that normally we're not going to have quite as many speakers at our next session. So I think we'll be able to keep it to an hour and a half limit. But I feel like there was just so much excitement around this topic that it was a bit challenging, and so many excellent teams working on this issue that it was hard to narrow it down further. And I think it was really helpful to have different perspectives. I hope you agree. I suppose those that are tired of it aren't here to hear me say that. So, but I'm hoping that in the next sessions, we'll have more time for everyone to introduce themselves. I'm sorry, because I can see a lot of our ICI teams in our participant list, and we haven't gotten to hear from everyone. Are there any quick closing comments? If not, I would like to thank, I'm just checking in the chat. So there have been questions about the ICI questionnaires. I think everyone should have my email address. I'll put it now into the chat actually. My email is mtherrien, mtherrien @icicHildbirth.org. If you send me a message, I can give you information and links about the ICI questionnaires. And we will probably have a full session for people who are new, who want to know about the process of being an ICI, the use of the questionnaires. I really appreciate that a lot of the teams talked about how the questionnaire sort of tied into their work. People are still joining. I want to thank all of our speakers. If this time is good for you, please mention that in the chat as well. If this time will work well, I think we're going to stick with this. I think we had a good turnout today, and good coverage. I know it's a bit early for some and late for some, but I think this is a good balance. Deborah, would you like to help us close out? Because I think Ray is not able to unmute.
Yes, I am here.
Oh, good, Ray, finally.
I am so impressed. And I'm just so happy to see that, the word doula has gone global, and you all have just played such an important role in this important role as a doula myself and as a doula trainer. And I so appreciate all the work that you all have done, and I look forward to working with you all again. Thank you.
Thank you, Ray, and thank you, everyone. It truly is exciting to see the work that's being done, the interest that's happening globally for continuous companionship and doulas and Step 4. And today, one of our dear doula mentors and leaders is transitioning and passing on. So I'm being here holding space as she transitions, but also I know that us coming together and really talking about doulas around the world is exactly what she would want. She's been such a part of doulas beginning. So I just want to thank you all so much from the bottom of my heart for all that you're doing for the ICI, for the care for mother, babies, and families in your communities and around the world, and for coming together with us today to share. It just means so much to us, so thank you.
Thank you, Deborah. You're actually also reminding me that from the Lwala team, the person who first brought this idea forward during the ICI pre-Congress session years ago now, is Doreen, who passed away on February 14th this year. And I was just thinking also about, if she hadn't spoken up, that we may not have brought this program forward with Lwala. And I'm really sad that she's not here to watch it go forward. But many thanks to all of the teams today for all of your inspiration. And I'm hoping that we can have more sessions. If there are topics that have come up today that you want us to explore, please go ahead, put it in the chat, send an email, because we are developing topics for the rest of the year. We're going to try to keep this going as long as we have material to continue. And I think that will be going on for quite some time. Thank you so much. Wishing everyone a very good day or a good evening wherever you are. And I hope to see you all back with us in a couple weeks.
Thank you, everyone.
Thank
you.
Enjoy
your
day.
Thank you from Germany.
Bye, everyone. Thank you.
Thank you.
Thank you.
Bye bye,
Bye.
everyone.
Thank you. Bye.
Bye.
Bye bye.
Bye bye.
Bye bye.